This is episode 738 of the Rio Grande Foundation's Tipping Point, New Mexico. I'm Paul Gessing, president of the Rio Grande Foundation, New Mexico's free market think tank. You can find out more about the foundation at riograndefoundation.org. I am very pleased to be joined by Dr. Deane Waldman, who once upon a time was on the board of the Rio Grande Foundation. He was also a pediatric cardiologist at University of New Mexico Hospital, so a resident of the land of enchantment who now lives in Texas and still very active in public policy, especially in the medical issue area. And he has helped create the Empower Patients Initiative, and we'll put link into the show notes on that. But welcome back to Tipping Point, New Mexico, Dr. Deane Waldman, MD, MBA, not a combination you see very often.
Glad to be here and glad to talk with you today.
Yeah, well, it's great to talk to you again, Deane. And why don't you start us off by just giving people a refresher? It's probably been a couple hundred episodes since we had you on. So tell us about your track record and history, especially as it pertains to practicing medicine in the state of New Mexico.
Yeah, I practiced, I trained at all the sort of right places, um, um, Yale, Harvard, Northwestern, Mayo Clinic, etc. Um, it's actually interesting how I got to New Mexico. I was at the University of Chicago. I was a chief there, and I was very unhappy because all the things that were in my recruitment package at the University of Chicago related to trying to make the system more patient friendly, and they didn't do any of it, despite the fact that I had a contractual obligation. And after, I don't know, 5, 6 years, I said enough of this garbage and started looking around. And it turns out that the University of New Mexico offered basically the same thing to me, which was building out a system, a structure that was patient friendly, like having human beings answer the telephone, like prompt appointments, all these things that are hard to get at many university hospitals. And so that's the reason I actually came to New Mexico, was because they offered me the opportunity to build something that actually was centered around patients rather than centered around my research.
Right. And eventually, for personal reasons, you had to retire. That's kind of, you guys are like airline pilots, pediatric cardiologists are. You did have an MBA, you do have that, and you have, not just a medical background, but a business background. And now you work primarily with policy reforms and solutions, and do it from Texas and with our colleagues at the Texas Public Policy Foundation. So um, let's dive right into the Empower Patients initiative that you and our friend Vance Ginn, the economist who's been on this show, that you are working on. So I'm seeing information at Americans for Tax Reform about this, but Empower Patients Initiative is a project that you are working on relating to uh, increasing the quality and access to care while reducing prices. So, what are you trying to do with that aside from just those things? What are your
Well,
policy goals?
okay, the basic issue is really, in a sense, very simple. Everybody makes healthcare and medical care a very complex issue, and it is, but the problem is it need not be, and it shouldn't be. By that I mean you should have a one patient and a one doctor relationship, connection, call it whatever you will, without a third party in between making decisions. And that is actually, I just said in one sentence, The reason why our healthcare system doesn't work is because that relationship, that direct connection between a patient and a doctor that the patient chooses, or an APRN. I'm really happy with APRNs between you and me.
Well, hold on. We'll talk about APRNs because that's a new one by me. But why don't we have direct relationships as patients with our doctors?
Okay,
Explain that.
again, simple question, simple answer. Well, actually, complex question, simple answer. You remember that everybody knows the golden rule: you do unto others as you would do as they would do unto you. Well, that's the biblical golden rule, but there is a modern golden rule, and that is he who has the gold makes the rules. In other words, he who controls the money controls everything else. And the point, the segue here is that the patient, who is the consumer, if you will, in the healthcare market, so called, the consumer, the patient, doesn't control the spending of his or her money. And that is what the Empower Patients Initiative tries to accomplish, which is returning control of both the money flow as well as, therefore, the medical decision making process, return that control where it belongs, which is in the hands of what we call we the patients rather than third parties.
Okay, so correct me if I'm wrong, but that all started to take place in the United States during World War II when you had wage and price controls and businesses were trying to keep and retain and attract employees because, of course, during the war, there was a shortage of workers. And so they started offering fringe benefits like healthcare as one benefit. And then ultimately that was locked in. 1954 was a big tax bill, and tax exemption was given to employers for providing health insurance to their workers. And so that really, in my estimation, started to sever the tie between the patient and the doctor. Now, of course, there's been a lot of additional programs and government's gotten much more involved with Medicaid, Medicare, et cetera. But is that a summary that you can go with in terms of why we got to where we are today? Or feel free
It
to
is,
put some
it
flesh on
is
the bones.
It is the key element. You just identified it, because when you think about it, the healthcare benefit, the employer supported health benefit, is really not employer supported. That is a holdover, just as you said, from World War II. That's 60 odd years ago, World War II wage freezes. Now, the reason I say this, and I have to
That's 80
emphasize it, is,
years, 80 years, Deane. Sorry, time flies, but we
well,
just,
for
I don't
us
know, you want to
80-year-olds,
say it's celebrated, but we just had the commemoration of the 80th anniversary of the bombing of Nagasaki and
yeah.
Hiroshima. 80 years.
Well, time flies when you're having fun. What
I
can
know,
I
I know.
say? Yeah, you're right. But the issue really is that that money, which is last year averaged $23,968 per employee, that money is not the employer's money. That is wages that the employee earned that should be given to the employee. And the first phase, if you will, the first stage of the Empower Patients Initiative is to say, okay, they eliminated after World War II all the wage freezes and price freezes except one, which was this healthcare benefit, so called. So we say, okay, now do to that what you did to everything else, which is give that money to the employee. Then we turn around and say, Vance Ginn and I say, turn around and say, okay, now the employee just got $24,000 of money that currently is going to an insurance company. which then controls everything else because they have your money. We say, give that to the employee and let him put it in an HSA and let him or her, them, go shop for, that's 157 million Americans that we're talking about here. Let them go shop for care, shop for insurance, no federal requirements, regulations, other than the fact that it's tax-free if you use that money for anything that's medical. And suddenly you would have a market of multiple billions of dollars that can be spent by the patients for their own care and their own insurance.
I would love that to be the case. Obviously, that is a not a situation where the powers that be of either party seem to be ready to take us. But is that because businesses lobby to keep that tax advantage? It would seem like a thankless task, by the way, to be the employer and have to add to your numerous responsibilities, purchasing healthcare for your workers, especially when the prices keep going up and things keep kind of becoming more and more difficult and problematic when it comes to healthcare. But why can't we all just agree? Yeah, take this tax advantage and either eliminate it completely, or shift the money over to the workers themselves.
You're right about businesses. They would be happy with this Empower Patients initiative. The problem is insurance lobby. The problem is hospital lobbies. The problem is legal lobbies, and not to mention the entire federal bureaucracy. I don't know how many tens of thousands of people work for just CMS, Centers for Medicare and Medicaid. Well, suddenly, by doing that, essentially, we'd eliminate their jobs because now people control their money and they are not overseen by regulators or by insurance executives. And those people would lose power. They would lose money and lose power. And so they would strongly oppose this move that we suggest. By the way, the doctors initially would not be happy with this either because they're not used to competing with each other. Or should I say, we're not used to competing with each other. But the fact is, health care, two words, the service. Health care is a business, and businesses thrive in a free market. And the fact is, those who give prompt care in that free market, the doctors who will see you tomorrow rather than 6 months from now, they're the ones that are going to have the patients in a free market. Right now, it doesn't matter whether the doctor sees you tomorrow or sees you 6 months from now, because it makes no monetary difference to the doctor. Suddenly, if the patient controlled the money, hey, you better believe you'd get a prompt appointment. And so that's Vance and I, as well as Americans for Tax Reform, and basically anybody who thinks about this, would say we need to return that control to the patients. And by doing so, they will get prompt care, they will get quality care, and they will get lower prices because doctors will be forced, hospitals will be forced to compete with each other for the patient's money.
Right. All right. Well, I think that's a good starting point to move forward in the conversation. You have listed at this at the ATR.org website, Americans for Tax Reform, a few key reforms, and I think kind of the no limit health savings accounts. That makes pretty good sense in terms of what we're just talking about. But the point two is deregulating providers and insurers to allow real competition and innovation. How would that work? You talk about providers and insurers, two very different groups of people, but what kind of deregulation are you talking about for providers and then insurers?
Okay, well, we'll do it the other way just because it's easier. Insurers. The fact is, right now, for example, the Biden administration literally eliminated what they call junk insurance. Drunk insurance. Yeah. In a sense. Yeah, well, anyway, um, what they call junk insurance was short-term insurance, and the insurance lobbies didn't want that because it gives more control to the patients and it's much cheaper. And so they sell, we say, imposed on the Biden administration, and basically they deregulate they regulated it out of existence. So we say, well, let the market, that is the patients who now have control of their money, they say, hey, insurance company, here's what I want. And Washington should not be in a position to say, no, you can't sell that to the patients. For example, best example, what most people would want, because most people are healthy or reasonably healthy. Yeah, you get a cold, God forbid your child breaks a leg. That's not the same thing as cancer or heart surgery or what I did, repairing babies' hearts. Um, Most people are healthy. And so what they need is they need to be able to shop for their care for a hernia repair or, diarrhea or an infection in your leg, and pay for it directly. And then they need catastrophic insurance that is very high deductible, which, if the you know what hits the fan, and God forbid you're in an automobile accident and you end up, in the ICU and you end up with $100,000 bill, the catastrophic insurance would pay for that after whatever your deductible is. So my point is, right now you can't do that. For example, my own um, health plan, which is Humana, my own health plan through the University of New Mexico, my own health plan does not allow HSAs,
Hmm.
will not accept catastrophic insurance. Well, of course, the insurance companies can't even offer it. So, what we're saying is deregulate the whole insurance system and let the consumers, that is, we the patients, let them say, hey, this is what I want. I want a policy that has whatever, or has these exceptions, or has this time limit, whatever it is. Let the patients, the consumers, decide, because they're the ones who control the money. So that's the insurers. You're talking about the providers. The providers will initially go, oh, wait a minute. Oh, what? You want me to compete with Dr. X down the block? Because deregulated, suddenly, right now, I have no choice. If I'm on a health panel, the panel has to obey whatever the federal regulations are, whether it's efficiency standards, how many patients I have to see in an hour, whether it's what I can do and cannot do for a patient. All this regulation comes straight out of Washington. When we say deregulate, we say, hey, let the doctors decide what they want to do, and what they'll do then in this system, in this empower patients system, is they'll do what the patients want them to do. You want to be seen tomorrow? Okay, I'll see you tomorrow. You want that hernia operation done under local anesthesia? Well, that's the safer way, so that's the way I'll do it. In other words, do what the patients want and need, not what Washington tells them to do. So that's deregulation of both the providers and the insurance companies. And by the way, let me finish that thought with, the insurance companies and the doctors will both initially resist this idea, but the fact is, at the end of the day, with this in place, they'll end up making more money and be happier.
All right. Well, sounds good to me, but you and I think a lot alike, Deane. So it's not a surprise. And we very much want to see market forces unleashed to improve American healthcare and Americans' health in a way that the system is obviously not getting the job done. Now, I know you are undoubtedly aware of New Mexico's medical provider shortage. You're also probably aware that New Mexico, to an extent that other states, are reliant on Medicaid, but we're number one on Medicaid reliance. And you mentioned replacing Medicaid's broken funding formula and providing federal block grants to the states. And the big beautiful bill. Feel free to touch on that. It does give some limiting factor to Medicaid spending at the federal level, but they did not go down the path, unfortunately, of block granting Medicaid. But talk about the issue of Medicaid and why it's such a knotty problem.
Okay, first let's talk, although I really want to talk, and don't let me leave without talking about what New Mexico can do. But
Sure.
Medicaid in general, the funding problem is one of, if you will, improper or misaligned incentives. Right now, a state like New Mexico, and let's ignore New Mexico for a moment and talk California. Right now, a state like California gets a percentage. In California's case, it's $1 for of federal money for every dollar that they budget. I didn't say spend. I said budget for Medicaid.
Mhm.
So, for example, when California puts 700,000 illegal residents on Medicaid, what they did was they increased their budget for Medicaid by over $3 billion, which in turn, the federal government then has to give them another $3 billion on top of the 80 odd billion that they're giving them in the first place. For New Mexico, um, New Mexico is, by federal standards, the poorest state in the nation, which means it gets the most money relative to Medicaid. Namely, it gets $3.1 for every federal dollars for
Mhm.
every $1 that New Mexico budgets for Medicaid. The bottom line is this: the more a state budgets, the more it can draw federal dollars into um, its Medicaid program. I cannot speak to New Mexico, but I can tell you, because I know, because I've seen the data, that California gets this money and then uses it for other things than healthcare. So this is, if you will, a great scam that encourages a state to spend and spend federal taxpayer dollars. We say, no, stop that incentive to spend. Give the state a block grant for X dollars, whatever. I forget what it is for New Mexico. I'm guessing around $7 billion, but somewhere in that vicinity. So instead of um, uh, tying it to the uh, uh, average wages in a state, and the budget of the state, the budget created by the state. Just give them that money and say, do what you think best with the money. Now, that's a very important statement. It has to be an unrestricted block grant. So the state can turn around and say, okay, well, we need to use those resources best here, wherever here is. For example, New Mexico might choose to say, and I think it should, hey, we should help rural New Mexico, those providers who are, whether it's a hospital or a clinic or an APRN or a doctor out in the rural areas, we need to support them, if necessary, give them more money than the people in Albuquerque, okay, or in Santa Fe. Why? Because they have bigger problems than the people in Albuquerque and Santa Fe. So bottom line is, we say block grant, which will stop the excessive budgeting in states like California anyway, and allow the state to be efficient and innovative in how to use the money that they have.
All right. Well, talk a little bit about more on Medicaid, because one of the things that we hear is that Medicaid and their low reimbursement rates uh, make it unattractive, relatively speaking, to practice medicine in New Mexico. And I realize that you may not have your finger on exactly what the reimbursement rates are, but just having a high, as New Mexico does, as you indicate, because we're considered a poor state, uh, talk about those reimbursement rates and why they may be a challenge in states that have such high Medicaid reliance for those medical professionals.
Well, you're absolutely right. Medicaid has a terrible reimbursement rate. For example, and I can give you direct example because I know my own experience. This is data from 10 years ago, but just you'll see the relationship. My average charge for doing a procedure on a critically ill newborn baby, say a cardiac catheterization, or I have to do a balloon procedure, or whatever I have to do, average charge was around $2,000. Medicaid paid, didn't matter what the charge was. Charge could be $10,000. Whatever the charge was, their maximum allowable reimbursement for a procedure on a newborn baby by Medicaid was $387. Now, just think about
Mm.
that when you translate that to a primary care doctor whose charge might be $50 for an office visit, only he gets paid $14.
Mm-hmm.
Well, you can't even stay in business with these reimbursement rates. So, unfortunately, I have to say that one of the things I would recommend in terms of reimbursement rates is, if the state had control of Medicaid dollars, namely the block grant, one of the things they would have to do is increase the reimbursement rates for primary care. Now, it should increase reimbursement rates for everybody else. That's true, like pediatric cardiologists. I mean, paying me $387 for saving a newborn baby's life with hours and hours of procedures and preparation and stuff, not to mention all the years of training, is really obscene. But I'm more interested in the primary care than in the specialists, quite frankly. Specialists can make money on the tests, the things like echocardiograms and the special tests that you do, whether it's a urologist or a kidney doctor or a pediatric cardiologist. You can make up the low reimbursement by the money you get from the very high-tech tests. Primary care doctors can't do that. So
Mm-hmm.
you need to pay them more money for their cognitive activities. So that's the best I can say about Medicaid reimbursement rates. Let me change subject, because I know you want to talk
Sure.
about this, and I want to talk about it, which is Medicaid, New Mexico's doctor shortage, specifically of primary care physicians. You were going to chime in?
No, no, I'm just saying, yeah, absolutely. That's something we definitely need to talk
All
about.
right.
Primary care specialists, the whole 9 yards. We're short all of them.
Well, there's no question that New Mexico is. And let me start off by saying the following. There is I wouldn't say a very close, but there is a good relationship between where a physician trains and then stays there.
Mm-hmm.
It's not so much the medical school, although that is a bit of an element. But when we finish medical school and you want to be a primary care doctor, you want to be a pediatric cardiologist, whatever you want to do after medical school, you look around and say, okay, where can I get the best training to do that, whatever that is? And in this case, we're talking about primary care. So you're talking about family practice doctors, you're talking about pediatrics, something that I did, women's health, internal medicine. These are primary care specialties, if you will, where the doctor trains. We should not forget about APRNs, but we'll get to them later. Where the doctor trains tends to be where the doctor is going to stay to practice. So if New Mexico had the most attractive, the most hard to get, but large numbers, residency training programs, so that people, whether you're in California or in Vermont, go, well, I want to go into primary care, and I've finished training at Harvard, and I got all these credentials, and I'm very smart, and I want to go into primary care or internal medicine. And I know it sounds weird, but that program in New Mexico is just better than others. Everybody loves it. The guys and the ladies get great training. Now, how do you do that? Well, one of the ways you do that is by involving the private community in the training of the physicians. When I come from a medical family, everybody in my family has been doctors. My uncles, my grandfather, my father, they all rotated, spent time in the university hospital training residents. By the time I got into pediatrics, before I went into pediatric cardiology, we only had an occasional private doctor rotating with us. It was the academic physicians who sort of trained us and taught us. The point was, yeah, they were good, and yes, they were smart, and yes, they did great research, but they were less practical, less real world than the guys who were out there doing this every day. So I say, get that back into the residency training programs in New Mexico, involve the community. You will get two really good things from that. Three. Number one, you will get private doctors more engaged with, if you will, the university hospital. Number two, you will get trainees who get real world experience. And number three, and here's where we come to solving your shortage problem, those primary care doctors who are out in the community need help. They need more people when they're finished training to stay here. Well, they'll offer these residents jobs and say, when you're done with training there, Dr. X, we've got a great practice and we are busy as hell, and we can pay the following salary and the lifestyle here. And this is a wonderful state, and the people are very friendly, and the community loves us. And suddenly you're going to have more people training at UNM and in primary care, and then staying in New Mexico. That is the way you attract and keep people in New Mexico.
Now, certainly that is obviously a tried and true way. When I talked to a doctor who also happened to serve in the legislature here in New Mexico, and I asked him about keeping doctors here, he did say, doctors are people too. The education system's ranked 52nd, 50th, 51st, depending on the report. Crime is an issue. I mean, there are plenty of nice aspects to New Mexico, but when you factor in the low reimbursement rate, the heavy Medicaid dependency, and then some of those other factors, that makes New Mexico on the margins unattractive to a lot of doctors that might be starting out. You live in New Mexico, and I realize that that may not apply to you, but what is your take on some of those kind of side issues? We'll just call them.
Well, I wouldn't actually call them, they're big issues. Whoever said this is absolutely right. The reimbursement thing has to be dealt with, quite frankly, on the state level. Assuming we get a block grant system, the state is going to have to change the reimbursement schedule, because remember, if the state has an unrestricted block grant, then suddenly it can, pardon me, it controls the reimbursement schedule, not the federal government. So for New Mexico Medicaid, under control of New Mexico can say New Mexico Medicaid, not federal Medicaid. New Mexico Medicaid can say, no, we're going to pay, your primary care doctor's charges are $50 for an office visit. We're going to pay him $50 for an office visit. And suddenly, if the state had control, the state could pay what it thought was reasonable and could keep doctors in there. That is the only way, as long as Washington controls the reimbursement rate rather than the state, or better, the patients. Because remember, in my world, the world I want, the empower patients world, it is the doctor's charge that brings or keeps away the patient from coming in that office. So the doctor, on the one hand, wants to get paid his $50, but if the doctor next door is charging 45 and the patient is equally happy with either doctor, the doctor's going to go to the patient's going to go to the 45. In other words, if you throw in, and you use the phrase, I was staying away from it a while ago, you use the phrase market forces. If we get, because I didn't want to get too academic, if we get the power of the dollar in the patient's hands, suddenly you will see prices go down and happiness, both providers and patients, go up. But the key is the golden rule, the modern golden rule. The patients have to control the money, period.
All right. We have, there's one more thing I want to talk to you about, which is the medical malpractice issue. And New Mexico is a notorious, problem when it comes to medical malpractice. There are some free market folks who don't believe that medical malpractice should be capped or reformed in a dramatic way. It's not in your, at least the brief sheet you have on the Empower Patients initiative, but you did practice in New Mexico, and it's been a few years, but talk about medical malpractice issues as you see them.
That is we're going to have to spend a whole nother episode on that, but and I'm going to give you an answer that's going to be a guarantee unsatisfactory, but I'll give you the right answer. The right answer is the whole medical malpractice, the whole idea of tort reform is flawed. The fact is, the malpractice system that we have for the country, not just for the state, for the country, is inherently structurally wrong. By that I mean it is based on criminal law, so that the malpractice, the tort system for medical malpractice, focuses on three things that almost have nothing to do with a patient having a bad outcome. Number one, identify the perpetrator. I mean, this is legalese. This is directly out of the whatever the what's his name, tort lease and something or other. Anyway, Prosser on torts.
Okay.
which is the textbook for tort the legalese for tort. All
You're
right.
only an MD and an MBA. I can't expect you to slap on
Well,
an attorney
I,
hat as
I
well.
threatened my mother. I went back to business school at age 55, and she wondered what the heck I was doing. And I said, I think I can be a better chief and a better leader if I have these business tools. She said, "Well, what are you going to do after you finish business school?" And I said to her, I was thinking of going to law school. I thought my mother was going to have a heart attack because one degree I don't have. Anyway, back to tort. So the medical malpractice system has three goals. One, identify the perpetrator. Two, make the perpetrator accountable. Three, make whole the victim. Those are the three sort of goals of the tort system and therefore of medical malpractice. Well, in the vast majority of bad outcomes, there's no easy way to identify any person who did something wrong. The fact is, and especially did something negligent. The fact is, most of the time, people do things right, and patients have bad outcomes because we can't fix everything. I won't go into further on that. Just take my word for it. If you look at the data, that statement is true. Number two, make that person accountable. Well, wait a minute. The patient who died on the operating table because he was having stomach surgery because he weighed 500 pounds and he died on the table or shortly after the surgery, and you're going to blame the surgeon? Well, excuse me. The patient was a very high risk patient, and a lot of people with, for example, morbid surgery do in fact die because it's high risk. Nobody did anything wrong, but the system will suddenly sue the doctor. The doctor will settle, and this fails at what the system should be doing, which is number one, figuring out what they can do better the next time rather than this time. In other words, identifying the perpetrator is a flawed, a wrong goal. It shouldn't be focusing the blame and then shaming that person. It should be, what can we learn from this experience? Well, the whole system we have now, for example, of hiding the data on a bad outcome because of confidentiality and legal liability, we should do the opposite. We should uh, um, throw the whole thing open to say, hey, who's got an idea of how we can do this better? Because the patient died, and we obviously didn't want the patient to die. So, how can we learn from this? Until we change the system itself, we can't really make medical malpractice work to the benefit of patients or to protect the providers. So I'm sorry, I'm sure that's a unsatisfactory answer, but the fact is you can't reform what we have now. You have to replace it.
All right. Well, we're going to have to more or less leave it there. If you have any further information or something you think we needed to talk about before we hold up, we conclude this conversation, please let me know. But
Okay, I'll
any,
say something right now. The
sure.
fact is that whole Empower Patients initiative is the right answer, but, and here's where the huge however comes in, which is there are very powerful forces that will resist their loss of power, turning the power over to we, the patients. The only way we will get this going, which is why we wrote the book that I'm going to tell you about in a second, the only way we can get this going is by having a groundswell of, and I mean this literally, tens of millions of Americans who go to their state legislators. You can never get a hold of your federal senator or your legislator unless you're a billionaire. The fact is, They don't talk to us normal people.
Mhm.
So don't bother trying to get, but if you can get to, and most of us can, certainly in New Mexico and here in Texas, everybody in a community knows who their representative is because you see them at the grocery store or whatever. Anyway, get to your state representative and say, we want this, and we want you to lobby the feds, our state senators and representatives, the federal ones, get the state guys to talk to the federal guys to say, hey, our constituents want this. They want the Empower Patients Initiative, and I'm not going to get reelected if I don't say to you, do this, and you're not going to get reelected if you don't do it. So we wrote a book, not like the paper that you mentioned earlier, and people are welcome to read the Americans for Tax Reform paper, which is called the Empower Patients Initiative. You're welcome to read that, but it has financial models in it. It has technical details that are necessary for the politicians and the policy wonks. But for the public, we wrote a book called Empower Patients, Two Doctors Cure for Healthcare. And that is for the average American. That is for not even you, because you, Paul, you know too much about the system, but for average people to understand why they should want and demand the Empower Patients Initiative. They need to read Empower Patients, Two Doctors Cure for Healthcare, because it's easy reading, it's short, and it explains what I just said in the last whatever, but in more easy to read detail, if you will. And the whole point I'm trying to make is we need, that is you, me, Vance, and those of us who really want to fix healthcare and understand that it's truly broken. We need to get millions of Americans to read that book and then demand the power.
All right. Well, thank you very much, Dr. Deane Waldman, MBA, also by your name. And good chatting with you. And we will talk to you again soon. Thanks for listening to this week's episode. Find all episodes at tippingpointsnm.com or at the Rio Grande Foundation's YouTube channel. Subscribe to this show at Apple, Stitcher, or tell Google Home to play Tipping Point New Mexico. Thanks to Path 3 Marketing for producing this show.